Radar, and today I'm going to be talking about thyroid physiology. As a reminder, this is for educational uses only. I don't own any images that I use. Everything is the property of whatever the cited text is. For this lecture's case, that would be Endocrine and Reproductive Physiology, 5th edition of the Mosby Physiology series. All right, so before we get started, I want to sort of outline the general structure of a thyroid follicle. So a thyroid follicle is made of thyroid cells that are all going to, they're cuboidal and they're going to be all lined up in a circle. And inside the circle, you're going to have this colloid, all right? And this colloid contains thyroid hormone bound to thyroglobulin, all right? And this apical membrane represents the side that's in communication with the lumen of the follicle, and the basal membrane, right? So this apical membrane is in communication with the inside of the follicle, and this basal membrane is in communication with the rest of the body, right? So the blood supply, etc., and that's where the iodine is going to come from. Okay? So iodine gets imported into the thyroid gland through the activity of the sodium iodide symporter. It's called the iodide trap because it can gather very large amounts of iodine, and it's a form of secondary active transport, and it's paired to sodium potassium pump function, which you would expect because it's a sodium iodide symporter. The energy has to come from somewhere, especially because the iodide is coming in against its concentration gradient. So once the iodide is inside, you're going to notice that there's a sort of two-directional synthesis pathway. First of all, the iodide and the thyroglobulin has to be bound together in the presence of certain enzymes to form thyroid hormone bound to thyroglobulin. All right? So the thyroglobulin is synthesized in the endoplasmic reticulum. It goes to the Golgi and then it's packaged and targeted to go be exocytosed into the apical side of the thyroid cell. And that is going to make sure that it is available within the lumen. And the iodide is going to come in through this sodium iodide symporter. It's going to go through this process and be secreted through the pendrin transporter. All right, so that's important. The thyroglobulin and iodide are bound. So this is the first direction, going towards the thyroid follicle. Okay, this is the colloid. This is the colloid. So this represents the components of what's going to make the thyroid hormone bound to thyroglobulin. First, it's going to move from a basolateral to apical direction. All right, and then it's going to come back inside. You're going to see that vesicles are going to form, endosomes are going to bring in thyroid hormone bound to thyroglobulin, and proteases are going to break down these components so that you can release the free T3, T4 back on the basal side. So it goes in one direction, then it comes back the other. All right? And there's a couple of things I want to point out. This pendrin transporter can be mutated in a few disease states, and we're going to talk about that. It's called Pendred syndrome. There's the sodium iodide symporter is regulated by a number of things. For starters, and this shouldn't surprise you, but when the anterior pituitary secretes thyroid stimulating hormone, the thyroid stimulating hormone will upregulate the sodium iodide symporter. And that makes sense because you want to increase thyroid function through thyroid stimulating hormone. You want to increase the amount of iodide that's available. Additionally, it's going to be inhibited by inflammatory cytokines, and that's called the sick euthyroid syndrome. Okay, that is sick euthyroid syndrome. And there's a one or two other things that contribute to the sick euthyroid syndrome. But what I want you to understand is that when you're sick, the inflammatory cytokines directly suppress this symporter. All right, when you're sick, you directly suppress the symporter. It's not because you have hypothyroidism or hyperthyroidism that the thyroid is dysfunctional. That's why it's euthyroid, true thyroid. But you have a sick true thyroid. Because you're sick, NIS is downregulated. All right, and additionally, the presence of iodide itself can eventually inhibit the sodium iodide symporter. The less iodide available, the more active this symporter is. So when there's not a lot of iodide available, that productivity can go up to 90%. When there's too much iodide available, it becomes less and less and less active. And that's part of the reasoning why when you're going to do thyroid surgery, you provide very large amounts of iodide because you want to inhibit this process so that you don't cause thyroid storm while manipulating the thyroid gland. So just to recap real quick before we move on to the next slide, iodine comes in through the sodium iodide symporter. It enters the colloid through the pendrin transporter. It's bound to thyroglobulin, and then that thyroglobulin, MITDIT, the thyroid hormones bound to that whole complex, comes back in. All right, it comes inside this endosome, and then it's cleaved by proteases, and the free thyroid hormones are free to circulate. So because of how the thyroid gland traps iodide through that symporter, you can actually measure how functional the thyroid is by radioactive iodine uptake. All right, radioactive iodine uptake. Okay, so what happens is you'll inject iodine, um, a radioactive iodine isotope, in case it wasn't obvious, and you're going to place a gamma detector on the neck right here, because remember, the thyroid gland, where is it positioned? It's positioned right here. All right. So what you do is you put the detector right here on the close to the thyroid gland, and you can detect the radioactive uptake. So you do that after 4 to 6 hours, and then after 24 hours. Okay. And you don't need to know after every 4, 6 hours, 24 hours, etc. You don't need to know that. What I want you to understand is that by providing iodine, because there's an iodide trapped in the thyroid, and that's where all the iodide, almost all the iodide in the body goes, understand that iodine is going to be concentrated in the thyroid, and radioactive iodine will be concentrated in the thyroid. And because radioactive iodine is concentrated in the thyroid, you're now able to measure the radioactivity, and that tells you how active the thyroid is, because the more active it is, the more iodine it's bringing in. So let's take a look at this graph. Here you see there's a normal, what do you call it? A normal uptake. All right. In hyperthyroidism, that's very exaggerated. Okay, that's very exaggerated. So abnormally high radioactive iodine intake, and that's going to be about 60% or more, indicates hyperthyroidism, especially if it's after 24 hours. Abnormally low radioiodine intake, so that would be this graph right here, indicates hypothyroidism. In the United States, that's going to be about less than 5%. So in individuals with extreme chronic stimulation of the thyroid, like in Graves' disease, iodine is going to be trapped, organified, and released as hormone really rapidly. Okay, so that's what this represents. So let's say someone has Graves' disease, so it's not just hyperthyroidism. Let's say they're hyperthyroid and they're now in thyroid storm. You're going to have extremely high turnover of iodine. So think of it this way. In normal, just hyperthyroidism, yeah, the thyroid is busy, but it's busy at a rate that keeps incorporating iodide. In thyroid storm, the concern is that there's so much thyroid hormone being made that yes, the iodine concentrates initially. You provided the radioactive iodine and it concentrated initially, but it's being so rapidly turned back into thyroid hormone and exiting through the basal side of the thyroid cells that it's not even gathering there anymore, and it's disseminating throughout the body. So that's what this graph represents. This is normal, this is hyperthyroid, this is hypothyroid. In an organification defect, um, note that at first there's going to be uptake, right? So the iodine is going to be uptaken, but it's not actually going to be added to tyrosine when it's making the thyroglobulin thyroid hormone complex. That's just not going to happen if there's an organification defect. So what happens is the iodide will be released back out of the gland because it's just not being used. All right. So that's what this graph represents. And what can also happen, what can also cause this, is the administration of anions such as thiocyanate, perchlorate, and pertechnetate. Administering any of these will inhibit iodide transport through the sodium iodide symporter. So if you admit it, you can use perchlorate as a method of preventing that iodide uptake. All right. So I don't want you to memorize this. I just want you to be able to reason Well, you definitely need to know normal versus hyper versus hypo just by looking at it. Um, but I want you to understand why the radioactive iodine uptake is such a useful parameter. So that brings us to our first clinical correlate, which is the Allan-Herndon-Dudley syndrome. And what this is that there is a transporter called MCT8 that brings the thyroid hormones, right? It brings the thyroid hormones into the neurons. MCT8 brings thyroid hormones into the neurons, okay? And if you knock out MCT8, you might as well not have thyroid hormones. You can't treat this by supplying extra thyroid hormone. Exogenous T3 and T4 will not treat Allan-Herndon-Dudley syndrome. And because you don't have thyroid hormone in the neurons, you get all the effects of hypothyroidism, and it's neurospecific. So you'll specifically get psychomotor symptoms. All right? You get psychomotor symptoms. And this cannot be treated with exogenous T3 or T4. Generally speaking, hypothyroidism will cause growth retardation. It'll cause mental issues, psychomotor deficits, and we're going to get to hypothyroidism later. But it causes if it's not recognized early in a child, a lot of things can go wrong. In this specific form, it's not hypothyroidism. It's just that you don't have a functional MCT8 transporter, so you might as well be hypothyroid because you can't bring the thyroid hormone into the neuron, and because you selectively can't bring thyroid hormone into the neuron, you get the psychomotor deficits or the cretinism. Cretinism is a word you should be familiar with. Cretinism as a result of not having enough thyroid hormone in the neuron. So for the Pendred syndrome, that's going to be a mutation in the pendrin gene. Now remember that if this is the membrane, the apical membrane of the thyroid cell, this is the cytosol, this is the colloid lumen, this is the lumen side with all the yummy stuff inside, and the pendrin gene is what pumps the iodide into the lumen so that you can make thyroid hormone bound to thyroglobulin. Now, if this pendrin channel is not working, then you can't do that. And what's that going to manifest as? Hypothyroidism. And the second thing that's going to manifest is going to be deafness early in childhood. And that's because the pendrin gene is required for the normal development of the inner ear. Okay, the inner ear will not develop properly in the absence of pendrin function. So when you see a patient who's hypothyroid, and they had deafness, and this is all happening early in childhood, you should suspect Pendred syndrome. And you can treat the hypothyroidism, right? That can be, and that usually is clinically detected and treated, but the deafness cannot be treated because no amount of thyroid hormone can fix a developmental process gone awry. And the third thing that can happen, and this isn't too high yield for STEP, is that the pendrin gene is expressed in the collecting duct of the nephron, in the aldosterone sensitive distal nephron. And don't worry about that too much right now. Just there is a susceptibility to metabolic alkalosis because usually this is involved in bicarb transport. So there's a susceptibility to metabolic alkalosis, but I don't expect that to be a high yield topic. What I really want you to know about the Pendred syndrome is that it's going to be hypothyroidism presenting with deafness. Okay? Hypothyroidism presenting with deafness. Now, let's talk about what is actually moving around in the body because you saw that T3 is secreted and you saw that T4 is secreted as well. T3 is the biologically active form. All right? So T3 is biologically active. And that's what's going to mediate the effects of thyroid hormone on the peripheral tissues. And it's this T3 that is going to feed back onto the pituitary and the hypothalamus in the feedback loop. Okay, because as T3, and this is extremely important, so please pay attention. This is maybe one of the most highest yield points I'm going to discuss. As T3 increases, it's going to decrease synthesis of TSH in the pituitary. And it's going to decrease the synthesis of thyroid releasing hormone by the hypothalamus so that you have less thyroid releasing hormone, and that's going to prevent the signaling that would promote TSH release. And on top of that, the TSH synthesis itself is being suppressed by thyroid hormone. And it's very important that thyroid hormone stays in the right range. Okay, so this feedback loop is really important physiologically. You must understand that as you increase T3, you're going to have decreased TSH and TRH from the pituitary and the hypothalamus, respectively. Now, when it travels in the body, when thyroid hormone, whether it's T3 or T4, travels in the body, it travels bound to thyroxine binding globulin, or TBG. This is different from thyroglobulin. This is thyroxine binding globulin, and it's made in the liver, okay? And it will bind one molecule, okay, of T4 or T3. So thyroxine binding globulin will bind one molecule of T4 and T3. So about 70% of what circulates is going to be on thyroid binding globulin. Now there's another thyroid binding protein called transthyretin. All right, transthyretin. This is a very important protein because it can form amyloid. So it can misfold and it can cause amyloid plaques and it can cause a form of restrictive heart disease. But what I want you to understand right now is that this is the other transportation form. So 70% is going to be bound to thyroxine binding globulin, and another 10 to 15 is going to be bound to transthyretin. All right? I don't want you to memorize the percentages. Just know that these are two molecules that are going to carry thyroid binding globulin. And the last thing you need to know, and this isn't too important maybe for STEP, but it is important to know for the broader context of clinical practice, is that thyroid hormone can also be bound to albumin. All right? And about 15 to 20% is going to be bound to albumin. So when you want to assess the free thyroid levels, you do have to consider how much might be bound to albumin. So if a patient has low albumin, like if a chronic liver failure, and actually that's a salient example because let's say you have cirrhotic liver disease and you're not making thyroid binding globulin and you're not making albumin, the thyroid hormone doesn't have anything to bind to. So that can change the measured levels. And lastly, what I want you to understand is that when we want to measure anything, whether it's thyroid hormone, no matter what the hormone is, you always want to correct for things like albumin. All right, that's just good clinical wisdom. If the hormone can be bound to albumin, or if, for example, sometimes hormones aren't specific, so one hormone can bind to a different hormone's carrier protein. And don't worry about that too much right now. I just want to plant that seed in your head that just because thyroid hormone binds to thyroid binding globulin doesn't mean that it can't be bound by other hormone binding globulins as well. So just keep that in the back of your head. To summarize the main points of this slide, thyroid hormone will feed back, the T3 form specifically, will feed back onto the pituitary and the hypothalamus to downregulate the release of thyroid stimulating hormone and thyroid releasing hormone so that there's a complete negative feedback loop. The thyroid hormone can travel with thyroid binding globulin, with transthyretin, with albumin, etc. And transthyretin can misfold and form amyloid, and this transthyretin amyloidosis, all right, this transthyretin amyloidosis can be cardiac, it can happen in the heart, and what it does is it interferes with the ability of heart muscle cells to contract, and that will cause a restrictive cardiomyopathy. All right, this is important. You must know this. It is critical that you know this. Transthyretin can form amyloid. That amyloid will interfere with the ability of the heart muscles to function properly, and that will cause a restrictive form of heart disease, cardiomyopathy. So there's a lot of different causes of goiter. whether you're hypothyroid or hyperthyroid, hypo or hyper, odds are you're going to get a goiter. So the goiter itself doesn't tell you anything. It just tells you what you need to start thinking about. And here's how you approach it, a patient with a goiter. First, you're going to look at their TSH and their thyroid hormone levels so you can understand a bit of the issue. But before we even get into that, we need to talk about primary versus secondary versus tertiary hyperthyroidism. In primary hyperthyroidism, the primary organ of synthesis is what's affected, so the thyroid. Okay, that's primary hypothyroidism, and you have excessive thyroid hormone being made. In secondary hyperthyroidism, it's the pituitary that's sort of out of control, and it's making excessive TSH. So the pituitary is making excessive TSH and stimulating the thyroid. And hypothetically, tertiary would represent that the hypothalamus, or the brain, is having increased TRH and then stimulating the pituitary to make the TSH. But do not worry about that right now. Most of the time, it's going to be one of these two. Okay, you have to identify, is this primary, is this secondary? In primary hyperthyroidism, because the thyroid is directly making stuff, you have increased T3 and T4. The primary organ is affected. Now this T3 is going to feed back and it's going to decrease the amount of TSH. Remember, there's a negative feedback loop. It's going to decrease the amount of TSH made made by the pituitary gland. In secondary hyperthyroidism, you do have that increased T3 and T4, but that's happening because of the increased TSH. So here's the difference. In primary, you're making more T3, T4, so you have decreased TSH. In secondary, and this might be a better way to write it, give me a second, you have increased TSH, therefore you have increased thyroid hormone. Okay? It's important to have that straightened out in your head. It's very high yield that the thyroid hormone feeds back onto the pituitary to decrease TSH. And in cases of secondary hyperthyroidism, the TSH is going to precipitate the increase in thyroid hormones. So the Wolff-Chaikoff effect represents the following. When iodine is increased, like excessively increased, you have decreased expression of a couple of genes, including DUOX, the symporter that I talked about earlier. Remember I had said how iodide inhibits the symporter, et cetera, and there were a few other things involved. Well, this is what they are. It inhibits these genes, and don't worry about their names. The point is that they're responsible for thyroid hormone synthesis. Okay, so excessive iodine decreases the expression of these genes, and that decreases thyroid hormone synthesis. So it's a built-in autoregulatory loop. Okay. It's very important that you understand that, because what it means is that we can provide a lot of iodine before thyroid surgery in a patient who's hyperthyroid. We can provide a very large amount of iodine before surgery, decrease the expression of these genes, decrease thyroid synthesis, so that we can safely operate on the thyroid and prevent thyroid storm or thyrotoxicosis during surgery. Okay? And thyroid hormones are going to increase oxygen use, energy production, and heat production. So everything's pushing towards we need to make energy. So when you have low energy, like when you're sick or you're injured or you're starving, you're not going to make thyroid hormone. Okay? So the synthesis of thyroid hormone goes down. On the other hand, when you have eaten a lot of food and nutrients are available, the body's like, okay, we can use this, and thyroid hormone is more active. Additionally, when you're cold, that'll increase thyroid hormone as well. Okay? So for Graves' disease, what I want you to understand is that there are thyroid stimulating antibodies. Okay? They are thyroid stimulating antibodies. They bind, so if this is the thyroid receptor, normally only thyroid stimulating hormone can bind here and increase the activity of the thyroid gland. However, in Graves' disease, you have thyroid stimulating antibodies that can also bind to this receptor. All right, even when there's no TSH present. And you're commonly going to see this, and as with all the autoimmune conditions, in women of childbearing age, so between 20 to 50. It's going to present as a diffuse goiter because the whole gland is uniformly stimulated by these thyroid stimulating autoantibodies. And you're going to have the symptoms of thyrotoxicosis, which are going to be weight loss because your energy expenditures are going up, sweating and heat intolerance. Why? Because remember, thyroid hormone, what does it cause? It causes uncoupling. And that uncoupling is going to cause you to burn a lot more heat per molecule of glucose. And so people with hyperthyroidism, sorry if I have to stop and pause a lot. I'm fasting for Ramadan, so throat is a little dry. Um, the heat intolerance is going to be a result of the lack of regulation because everything's uncoupled and you're producing so much heat. When you're in a warm environment, you can't tolerate it. So there will be intolerance to heat, loss of sweating. Additionally, there's some cardiac effects that we're going to talk about those, and that's going to cause rapid heart rate, palpitations, tremors, anxiety. I just want you to think there's like a that the thyroid hormone, not only does it increase like the contractility of the heart and stuff like that, but it's also going to potentiate adrenergic signaling. So everything that would happen with adrenergic, like the fight or flight response, it gets more intense with the presence of thyroid hormone. It's potentiating. You're also going to feel weak because your metabolic rate is going to be so increased by thyroid hormone. You're going to have weakness due to loss of muscle mass because your muscles are going to be proteolyzed and broken down for energy. And you're going to have sinus tachycardia with widened pulse pressure. Don't worry about that right now. The other thing you're going to see in Graves' disease is exophthalmos. You're going to see bulging eyes. And the reason for that is because the TSH receptor is expressed on orbital fibroblasts. So connective tissue cells of the orbit of the eye express the TSH receptor, not of the orbit, surrounding the orbit of the eye. And they will be targeted um, by those autoantibodies. And in the case of exophthalmos, there will actually be inflammatory damage and this periorbital edema. So you get this fluid buildup of the orbit, and it causes that bulging eye appearance because there's this pressure bulging the eyes out. So let's say this is the nucleus. And this is the stretch of DNA called the thyroid response element. Bound to the thyroid response element is a heterodimer consisting of the thyroid receptor itself and the retinoid X receptor. So there's a thyroid response element, and bound to it is the thyroid receptor and a heterodimer with the retinoid X receptor. And these will recruit co-repressors, okay? And these co-repressors deacetylate this region so that it's not so that the thyroid response element is not expressed. Now, thyroid hormone will bind to its receptor, and that sort of yeets and gets rid of these co-repressors, and it brings in co-activators instead. And then those co-activators will drive forward the synthesis of the genes under this thyroid response element. All right? So to summarize, the unbound thyroid receptor and retinoid X receptor heterodimer sits on the thyroid response element and represses it. In the presence of thyroid hormone, it activates it instead. So there's a lot going on here, and a lot of it is related to cardiac physiology, so I'm not going to belabor the point. I am encouraging you to go back to cardiac physiology and to review what these things would cause with regards to the cardiac physiology, but I'm going to keep things big picture. When you produce heat, that's going to decrease the peripheral vascular resistance. That's going to decrease the diastolic blood pressure, okay? And as a result, there's a reflex in the body that increases adrenergic stimulation. And a part of that reflex will increase cardiac rate and output. So that's the indirect arm of the thyroid hormone response. And it occurs secondary to the heat production of thyroid hormone because thyroid hormone uncouples ATP production from the electron transport chain so that when you do the whole process of glycolysis and citric acid cycle and electron transport chain, you don't make ATP, you're just making pure heat. And that heat production causes this. Some of the direct actions include activating the renin-angiotensin-aldosterone system. That's going to bring more fluid back into the body and increase blood volume. That'll increase cardiac rate and output. And some of the direct effects on the heart are going to include increasing the number of alpha chains. The alpha chains cause stronger, faster contractions. So that increases the chronotropy of the heart. If you don't know what that means, go back to cardiology and review. It increases the sodium potassium ATPase. That's important for resetting the, remember, at the end of the action potential, this needs to activate to bring everything back to baseline. It upregulates this as well. The sarcoplasma calcium ATPase is also upregulated. And that's important because the sarcoplasmic reticulum releases calcium into the cytoplasm, and that causes a contraction that's necessary for the heart to function, or any muscle, the skeletal muscle as well functions the same way. So upregulating the sarcoplasmic reticulum calcium ATPase in skeletal muscle and in cardiac cells allows a stronger contraction. Sorry, not a stronger contraction, allows less time between contractions because you're bringing the calcium back in more quickly, right? This ATPase is more active. It means you're bringing it from the cytosol back into the sarcoplasmic reticulum so that it's ready for when the next contraction occurs, you can release that calcium again. It potentiates beta adrenergic signaling. Don't worry about the G protein. It increases the contractility. At the end of the day, the big picture, all this stuff, the big picture is that it increases how fast and how hard the heart is beeping, not beeping, beating. And it can also, the other direct effect of thyroid hormone is vasodilation of arterioles. So at the end of the day, you have increased cardiac rate and increased cardiac output. So you can see why, and it's something like thyrotoxicosis or thyroid storm, you can see why it can cause death because the heart gets overworked. So something that I want to sort of illustrate for you is that when you're cold, you shiver, right? That shivering is the muscles are contracting to generate heat. What thyroid hormone does in the cold is that it uncouples the production of ATP from the mitochondria so that when you're shivering, you're not doing it to make the substrates, right? You're not going through the citric acid cycle to produce ATP. You're doing it just to produce heat. The ATP isn't made, only heat is made. So you go through the whole process, but only heat is made. And that's what happens in the muscles. When you're shivering, that's the point. When you're cold, thyroid hormone increases, and that helps with the shivering. Okay? We talked a bit about Hashimoto's thyroiditis. What I want to emphasize here is that it is immune mediated. Okay? So it is immune mediated, and it's destruction of the thyroid. And that separates it from Graves' disease, which is autoimmune stimulation, autoantibody stimulation. It's an autoimmune condition, but it's an autoantibody stimulation of the thyroid receptor. In Hashimoto's thyroiditis, it's destruction of the thyroid gland, and it's immune mediated. Now, what can occur with Hashimoto's is myasthenia gravis, and that's represented by, and we're not going to go into the pathophysiology of myasthenia gravis because it's beyond the scope right now, but that's what's going to be characteristic of it is weakness of muscle movements with repetition. Okay, so weakness of muscle movements with repetition is characteristic of myasthenia gravis, and it's because of autoantibodies against the acetylcholine receptor. Weakness of muscles with repetition, and you'll first notice it in the eyes, in like the arms, etc. So it's weakness that gets worse throughout the day. I spelled repetitions wrong. So weakness of muscles with repetition is going in a patient with Hashimoto's thyroiditis, or any, like if a patient presents has hypothyroid and a question stem, and they have weakness of their muscles with repetition, you want to be assessing for myasthenia gravis. All I want to emphasize about de Quervain's thyroiditis is that classically it will be in a patient with a viral infection. Okay, so in the question stem, the patient has a viral infection and then some issue with their thyroid, and that should prompt you to think of de Quervain's thyroiditis. All right, and it's transient, so no history of hypo or hyperthyroidism in this patient, but all of a sudden they're having some thyroid symptoms, and it's in the context of a viral infection. All right, so we're going to predict the changes in these parameters for the following conditions: Hashimoto's thyroiditis, exogenous thyroid hormone abuse, Graves' disease, and adenoma. So what I want you to do, I want you to pause and pull out a piece of paper, and I want you to copy this, and I want you to put up arrows and down arrows for what do you think happens at each condition. So go ahead and pause and do that. All right. So in Graves' disease, you have autoimmune stimulation of the thyroid hormone receptor. So the thyroid will make more T4 and T3. Because it's making more T4 and T3, it needs more iodine. So it will take up more iodine. However, this increase in T3 will feed back onto the pituitary and decrease thyroid stimulating hormone. So in Graves' disease, you're going to have decreased thyroid stimulating hormone, increased T4 and T3, increased radioactive iodine uptake. All right, now let's look at Hashimoto's thyroiditis. In Hashimoto's thyroiditis, you have autoimmune destruction of the thyroid gland. So your T4 and T3 are going to be decreased, your radioactive iodine uptake is going to be decreased, and your thyroid stimulating hormone is going to be increased. All right? For an adenoma, so that's Hashimoto's, for an adenoma, you have, let's say you have a tumor secreting thyroid hormone. This is going to be increased. This is going to be increased, but this is going to be decreased, similar to in Graves' disease. All right. And finally, exogenous thyroid hormone abuse. So people, because it'll increase the metabolic rate, people will abuse thyroid hormone for their desired purposes. Now, your TSH is going to be really low because it's going to feed back, but your thyroid hormone, your endogenous thyroid hormone, it could be normal or elevated. Okay, it'll probably look elevated because the person is injecting themselves with thyroid hormone on top of what you make, so it'll look either normal or elevated. Okay, most importantly, this radioactive iodine uptake will be decreased because the thyroid gland is not active. Okay, the exogenous thyroid hormone loops back onto the pituitary and decreases TSH. Because it's not the thyroid gland that's making the hormone, that decreases how much is made in the thyroid gland. And that will decrease its activity, and it will decrease the radioactive iodine uptake. So notice the only time that the TSH and the radioactive iodine uptake went down in the same direction is when you were using exogenous thyroid administration. All right, and that concludes our discussion of thyroid hormone.